Suture materials and its uses. Before we go on to the suture materials in itself, let's take a look at wound healing. Wound healing can occur by either primary intention or secondary intention or tertiary intention. Primary intention is when the wound edges are opposed by the surgeon or a doctor, and that leads to a normal healing with minimal scar. Normal healing means it's not like, the healing of a secondary intention with lots of granulation, tissue contraction, epithelialization. It's a very good healing. And in secondary intention, if there's a wound, it's not closed. It's not closed by the surgeon. It is, in fact, left open, and then there'll be a lot of granulation, contraction, epithelialization with increased inflammation and proliferation, and that will lead to a poor scar. Now, there's another term known as tertiary intention wound healing. That is when the wound is initially left open and later, after a few days or weeks, when the healing conditions of the wound are favorable, the edges are opposed, like that of a primary intention, but it's done at a later date, so it's tertiary intention. Now, what is the suture material? It is an artificial fiber used to keep wound together. Not actually artificial, it can be a natural material also, but we're trying to say is it is made up of something not from the body of the patient. So it's an artificial fiber used to keep wound together until they hold sufficiently well by themselves by natural fiber, like collagen of the patient's body, patient's wound, which is synthesized and woven into a stronger scar. A suture is a stitch or series of stitches made to secure the apposition of the edges of a surgical or a traumatic wound. This is the definition given by Wilkins, and Silverstein gave this definition in 1999. That is, any strand of material utilized to ligate blood vessels or approximate tissues is a suture material. So the goals of suturing are to provide an adequate tension of wound closure without dead space, but loose enough to obviate tissue ischemia and necrosis. Then to stop the bleeding, that is maintain hemostasis. Like wherever there's bleeding, we can suture that tissue up, so there's stoppage of bleeding. Then permit primary intention healing, that is easy to understand. Provide support for tissue margins until they have healed and the support is no longer needed. And to prevent bone exposure resulting in delayed healing and unnecessary desorption. So whenever there's any exposed bone, we want to take the skin flap or tissue and cover the exposed bone so that this problem of delayed healing and resorption does not take place. Through many millennia, various suture materials were used. They have been debated, and mainly it remains unchanged with some changes. The suture materials in the early days were made of plant materials like flax, hemp, and cotton, and from the animals, hair, tendons, arteries, muscle strips, nerves, silk, catgut. All these have been used and tried. The earliest reports of surgical suture was given in 3000 BC in ancient Egypt. The oldest known suture is in a mummy form from 1100 BC. A detailed description of a wound suture and the suture material used in it has been described by the Indian sage and physician Sushruta in 500 BC. The Greek father of medicine, Hippocrates, described suture techniques, as did the later Roman Aulus Cornelius Celsus. By 1000 BCE, Indian surgeons were using horsehair, cotton, and leather sutures. In the Roman times, linen and silk and metal clips were commonly used to close the gladiatorial wounds. The gladiators will fight with each other, there will be big traumatic wounds, and so they have been using linen, silk, and metal clips. In Africa, in the East African tribes, They've been ligating blood vessels with tendon strips. They've been closing wounds with acacia thorns pushed through the wound, or and even strips of vegetable matter. They were wound round these in a figure of 8. Like there's a wound, they will wind up the strips of vegetable matter so that the wounds are closed. Now, this is one interesting South American method of wound closure where they use large black ends to bite the wound together with their pincers or jaws acting like skin clips. These are the pincer or jaws. These will close. Let's say there's a incision over here. This will close it here, and after that they will twist off this remaining body of the ant, leaving the head in place, keeping the wound opposed. This they'll leave this part which is holding the wound. Now let's take a look at catgut and history about catgut. In the second century Roman physician Galen described gut sutures. In the 10th century, the catgut suture along with the surgery needle were developed by Abulcasis, and the catgut suture was similar to that of strings for violins, guitar and tennis racket, and it involved harvesting sheep intestine. So here in this diagram we have one plain catgut in a container. This is how they were stored. Joseph Lister endorsed the routine sterilization of all suture threads. He first attempted sterilization with carbolic catgut, and chromic catgut followed 2 decades later. Lister believed that catgut soaked in chromic acid prevented early dissolution in body fluids and tissues. That is why we have chromic catgut. So this is chromic catgut here in this diagram. Moynihan felt that chromic catgut was ideal as it could be sterilized, was non-irritant to tissues, it kept its strength until its work was done, and then it disappeared. So it was seen that chromic catgut was better than plain catgut. The chemical industry drove production of the first synthetic thread in the early 1930s, which exploded into production of numerous absorbable and non-absorbable synthetics. So the first synthetic absorbable was based on polyvinyl alcohol in 1931. Polyesters were developed in the 1950s, and later the process of radiation sterilization was established for catgut and polyester. Polyglycolic acid was discovered in the 1960s and implemented in the 1970s. Today, most sutures are made of synthetic polymer fibers. Silk and rarely the gut sutures are the only materials still in use from ancient times which are natural. In fact, gut sutures have been banned in Europe and Japan owing to concerns regarding bovine spongiform encephalopathy transmission, and because these cause an inflammatory cellular reaction with release of proteases. I've noticed that catgut is still quite commonly used in India for various purposes. Silk suture is still used mainly to secure surgical drains, and yes, silk is very commonly used for closing not only securing surgical drains but for skin closures, and very young doctors in the emergency department, they use silk sutures over the face for closing traumatic wounds, which should not be done, but they keep seeing their seniors doing that, so they follow the trend. Principles of suture selection. The selection of a suture material by a surgeon must be based on a sound knowledge of the healing characteristics of the tissues, which are to be approximated, the physical and biological properties of the suture materials, the condition of the wound to be closed, and the probable postoperative course of the patient. Now, these suture materials come in packets, and these have a thread and needles, and we need to know about how they are fit. The classification of sutures can be based on the origin, like whether it is biological or synthetic. Instead of biological, we can say natural, synthetic, or a bit casual term will be artificial. It can be braided or monofilament. Now, braided can be called polyfilament, and monofilament can be called non-braided. I mean, these are interchangeable terms. Then we have absorbable sutures or non-absorbable sutures. Absorbable sutures will disappear by hydrolysis or enzymatic reaction, and non-absorbable sutures will stay there. Like we've put the suture inside a patient, and if we open up the patient 2 years, 3 years, 5 years later, the sutures will still be there. And then we have coated and uncoated sutures. They can be coated with antibiotics or like that chromic cadguard. Now the biological sutures are silk and cadguard. This Merce Silk is a brand name which is by Ethicon, and here this plain cadguard is the suture name. There's no brand name over here in this one. So let's ignore this Merce Silk, and we have to refer it to as silk. Then the examples of synthetic sutures are all sutures apart from silk and cadguard. These can be polypropylene. Okay, these are brand names that I have mentioned over here. Proline, ethylon, monocryl, PDS2, ethibond, vikrill, vikrill rapide. I'll be coming to the actual names. Now the classification according to the filaments. So multifilament or braided. In this, the fibers are twisted or braided together. That means that there are, see, here's one fiber, here's another fiber. These are braided together. So these are 1, 2, 3, 4, 5, 6 multifilament. And then we have monofilament sutures, which appear as single strand of suture material like this one. This is a single strand. So, and all fibers run parallel. In this, there's no braided, and here obviously if we tear it apart, there's going to be small fibers inside. So it's like maybe it's made of multiple fibers. So, but it's all parallel, so it appears as monofilament actually. But then this multifilament here, monofilament, okay, but fibers can be multiple. It's not mono fiber. It's multiple fibers which are oriented parallelly, so it forms a monofilament which has a smooth surface. But in case of the multifilament, the fibers are twisted, so there are crevices where bacteria can lodge. And since this is smooth, it will be more slippery, and the knots will be more secure with a braided suture. Here is a picture of polyglectin 910 suture, which is purple in color, and we can see braided multiple suture fibers which are braided. So this is a polyfilament suture. So multifilament or polyfilament, we can use either terms. They have a better handling, they are much easier to knot, and they'll have a better grip. The surface area is about 1000 times that of a monofilament suture, because see, there's so many cracks, so many surfaces here. So thus they have a capillary action, and when something it touches a wet material, there'll be capillary action and the liquid will suck up the suture. The liquid won't suck up the suture, the liquid will climb up the suture, like some part of the suture will get wet, and there are interstices where bacteria may lodge and they lead to persistent infection. Here are some multifilament sutures. Now I have mention here the actual names and not the brand names. We have Silk. Commonly we get Silk, Mersilk, that's a brand name. Polyglectin 9, 10, and vikrill is the brand name. Here it is a coated suture, you can see that. It is undyed, this one, the packet I have, this one is dyed, so it's going to be white in color, not purple. And this is the suture name, polyglectin 910. Polyglycolic acid, then we have linen and polyester. Ethibond is the common name that we know, and Ethibond is polyester sutures. So here is the 10x magnification of a multi-filament suture, and I think this is the electron microscopy image. Smooth and not electron microscopy, I'm sorry, could be a very high magnification image. Monofilament sutures are smooth and they tend to slide through tissues easily, so they cause less trauma to the patient, to the tissues. There's no sawing action, less trauma, and they are less likely to harbor microorganisms. So if it's infected, could be infective tissue, or if it is an infected tissue, try using a monofilament suture over there. Memory and rigid. So since multifilament sutures have better handling, we'll say that monofilament sutures, they have difficult handling. And the knotting is also difficult, they are less secure. And these can be easily damaged by gripping it with a needle holder or forceps. So like when you use polypropylene sutures, you will note that if you grip it with a needle holder and lock the instrument, that part gets damaged, and later on if you just flick the suture, if you hold it and later you're flicking it like this, it usually fractures and tears apart. So this is how Prolene looks. It's all curled up, and therefore it's difficult to handle. So some monofilament sutures are polypropylene, polydioxanone. Polydioxanone is commonly available as PDS. Then polybutester, polyglyconate, polyglycaprone. Monocryl is polyglycaprone, Maxon is polyglyconate. So let's look at some differences between the monofilament and braided sutures. The monofilament sutures pass easily through tissue. The braided ones cause more trauma to tissues. The monofilament have less tissue reaction. The braided ones have more tissue reaction because they caused more trauma to the tissues. Now the downside of monofilament is that they are difficult to handle and therefore much more difficult to knot. So when young surgeons use polypropylene, it's quite, they look very clumsy while doing it because it's difficult to handle. When you keep the suture at a place, it'll move and it'll curl up, it's difficult to handle, and difficult knotting. So whenever we use polypropylene sutures for knotting, it is usually recommended that if you want to make that knot very secure, you have to have 6 or 7 knots. And braided ones have easier handling and knotting. If you have ever tied a silk suture, you would be knowing about that. It's quite easy. Monofilament are less likely to harbor microorganisms, and braided ones have a chance of microorganisms growing or not, microorganisms being trapped in between the braids. Monofilaments are rigid and braided is soft. It's soft, that's why it's easier to handle, and it is rigid, that's why it's difficult to handle. Absorption. This property must be taken into consideration when choosing suture materials for specific wound closures or anastomosis. Like in case of biliary tract or the urinary tract, one should prefer to use a absorbable suture because they'll get absorbed, there'll be nothing left behind. This minimizes the risk of stone production. And let's say you used a non-absorbable suture in the biliary or urinary tract, that suture will remain over there, crystals will get stuck over there, and that will act as the nidus for calculus formation. Like one suture will be present, then when the liquid, the bile or urine flows, small molecules and crystals will collect over this suture material which has not been absorbed, and then this will become a stone. Vascular anastomosis, non-absorbable material is preferred because persistent strength is required. You don't want to do an anastomosis and you don't want the suture to get absorbed in a couple of weeks. Then that will give a chance for the anastomosis to break. An artificial graft or prosthesis never heals fully or integrates into a host artery. So when you are putting graft for a vascular graft or something like that, then it never heals fully or integrates fully. So you want to use a non-absorbable material over there. Polypropylene is almost universally used wherever we want to use a non-absorbable material. It's the most common one that we use. Now some absorbable sutures are cadguard, polyglectin, monofilament, PDS2, Maxon. If you want me to use the actual names, it's cadguard, polyglectin. I've mixed things up over here. Polyglectin, polyglecapron, polydioxanone, polyglyconate. These are brand names: vikrill, monokrill, PDS2, and Maxon. These offer shorter term support because these will get absorbed after some time. Non-absorbable sutures offer longer term support, and these are silk, polypropylene, nylon, polyester, and these are brand names: Prolene, Ethylon, Ethibond. Silk does get absorbed, and we'll talk about that after some time. Now the strength of the suture. The strength of the suture depends upon the material, thickness, and how it is handled in the tissues. The tensile strength is the force required to break it when pulling the two ends apart. Like if I'm pulling the suture apart, I apply 10 units of force, then the tensile strength of this is 10 units. It is only a useful approximation as to its strength in the tissues because what matters is the material's in vivo strength. This tensile strength is being tested in vitro in the laboratory. We are going to put weights on either ends of the suture and test how much of force is required to break it. But when we put it in the tissues, there are reactions, there are so many other factors that affect the strength of the sutures in vivo, and that is what actually matters. And this tensile strength, which has been measured in vitro, is not an accurate estimate of the strength. The absorbable sutures, there will be decay of strength with the passage of time. Let's say there's an absorbable suture and it has a power of 10, let's say, and after some time it's going to disappear. It's just going to go away. So obviously, just before it is going away, its power is going to be 1, 2, 3, 5, 8. So first day there'll be 10 strength, then 8. So it's going to be, there'll be decay of strength. And non-absorbable sutures, it's not like its strength is going to remain 10, 10, 10 forever and then suddenly going to disappear. It's not going to be like that. There's going to be decay of strength. Non-absorbable sutures do not necessarily maintain their strength indefinitely and may degrade with time. Like silk, materials of biological origin, like the silk, will definitely fragment with time and lose their strength. Synthetic origin sutures like polypropylene probably retain their tensile strength indefinitely and do not change in mass in the tissues although it is still possible for them to fracture. If you have not handled the sutures properly and you have caused such, you held this part with your forceps and you've caused sort of damage to the proline when you use it inside the tissues. You've used a damaged proline. This part of the proline may be weak and that part can fracture and give away. Now let's take a look at how long the absorbable suture materials provide wound support and how long does it take for them to get absorbed. It's like, let's talk about vikrill. Vikrill is going to get absorbed after 50 to 70 days of being in the tissue, but then it's not going to provide support for that number of days. Till 30 days it's going to provide support. After 30 days it's going to be there in the tissue. If you open up the tissues, if you operate on the patient again, you will see the vikrill suture even after 30 days, at 40 days or 50 days, but they're just present like that. I mean, it's not going to provide any wound support. So that's why we have two terms, wound support and absorption, because it's not going to provide wound support till the time it gets absorbed. Its wound support is going to be less than absorption. So plain cadguard has wound support for 10 days and it gets absorbed at 10 days. But remember, there is going to be decay of strength. It's not like it has good wound support on the 9th day, just like the first day. Now, vikrill repide provides wound support for 10 days, but gets absorbed completely after 42 days. We have been using vikrill repide so regularly in our practice, and this is not well known by most doctors. So whenever they use vikrill repide over the skin, find that it gives wound support for 10 days, but they always advise to the patient that it's going to come off, it's no need to remove it and all. So when patients come after 2 weeks or 3 weeks, they always complain like, this thread is still hanging over my skin, and the doctors just dismiss them like, forget about it, it's going to come off. But then looking at this 42 days, it looks like it's not going to come off so easily. So it's better to cut it off. It's better for suture removal to be done by the doctor rather than dismissing the patient with some advice. Now, monofilament provides wound support for 20 days and gets absorbed at 90 to 120 days. Chromic cadguard provides wound support for 28 days and gets absorbed at after 90 days. PDS2 is a late absorbable suture, provides wound support for 60 days and gets absorbed after 180 to 210 days. So remember, even though PDS is still present and visible at 5 months or 6 months after operation, it is not providing support at that time. It provides support only for 60 days. Now, the size of suture material initially came as 1, 2, 3, 4, 5, 6, just like the size of our shirt, 36, 38, 40, 42, like that. So suture materials were also sized like that, 1, 2, 3, 4, 5, 6. But then the industry progressed and they were able to make suture materials of much lesser size than size 1. So what did they call it? They called it 0. Now they could make size smaller than 0. That was 00. And then smaller than that was 000. Smaller than that was 4 times 0. So this is 20, this is 30, this is 40. And it is not like minus. So it's not like 1, 2, 3, 4. And initially when I was studying MBBS, I used to think like smaller than 1 is 0, smaller than 0 is 10, smaller than 10 is 20. I used to think like this. But 0 and 10 is same. You are counting the number of zeros. So this 0 is 10. Smaller than 0 is 20. So there's nothing like 10. 10 is 0. And sizes can go up to 11.0 or 12.0. And the larger the number this way, bigger the suture size, and the larger the number this way in the 0 sequence, smaller the size of the suture. So this is a decreasing order of the suture materials. Now this is a metric system of the suture size and the USP system. So USP system is the old system, the 0 method. So we have 2, 1, 0, 2, 0, 3, 0, 4, 0, 5, 0, 6, 0, 7, 0, 8, 0, 9, 0, 10, 0. Now let's take a look at the diameter of a 0 size suture. A 0 size suture has a diameter of 0.350 to 0.399 millimeters. And then smaller than 0.350, that is 0.349 to 0.3 millimeters is 20. So it's 50. So you can remember one value, the value of 0, that is 0.35 to 0.399. Then you go 50 down and it becomes 20. But then for 30 you go 100 down, it becomes 0.2 millimeter. Then you go 50 down again, then you go 50 down again. So this range of diameter is going to be quite difficult to memorize, and there's no point of memorizing this. No one's ever going to ask you this in any exam, but this could be asked in maybe some quiz competition or things like that. So this 50-50 is going down. So there's 100 gap here, 100 gap here, and this 50 gap here, 100, 50, 50. Then here's a gap of 30, 20, 10, 10, 10. So this is going to be quite difficult to memorize, and then trying to relate this USP system to the metric system is also going to be quite difficult. Okay, metric system is easy if you memorize the range of diameter. It's like if it's 0.5, it's 5. If it's 0.4, it's 4. If it's 0.35, it's 3.5. 0.3 is 3. You know, so it's quite relatable. Here again, this is the USP designation, the diameter, collagen diameter, synthetic absorbable diameter, non-absorbable diameter, American wire gauge system. So we have 26 gauge needles, stainless steel wires, which are used for arch bars, putting arch bars in the maxilla and mandible. We commonly use 26. So the thickness is similar to USP 1 size. Okay. Tensile behavior. Suture materials behave differently because of the difference in elastic properties and plastic properties. Now, elasticity is the ability of a suture to regain its original form and length after being stretched. So this, I've stretched it, it regains its original length. So this is elasticity. And so I've pressed this, it regains, pressed, it regains the original size. So it's elasticity. Plasticity is if I stretch it and it does not return to its initial length. This is plasticity. ability to mold is plasticity, because I've stretched it and molded it. This one I cannot mold because it is elastic. So if I stretch it, it goes back. It's not moldable. It's not plastic. So sutures may be deformable, like the circular cross section may be converted to an oval shape by pulling or by holding it, stretching it. Or sutures may be rigid, which have the somewhat irritating capacity to kink and coil. Now, there's a term known as memory of the suture materials. It's when they keep curling up in the shape they adopted within the packaging. It's a reflection of its stiffness. Like you can see the suture in the image behind. It's curling up. It has been kept on the table, but still it's curling up into this shape, like as if it was in the package. So in order to kill this property, we need to do a sharp but gentle pull to diminish this memory. And if there's more memory, more of this curling up, then there's lower knot security, and the knotting technique plays a significant role in any suture line's tensile strength. So this memory plays a big role in the tensile strength of the wound after we suture it. Like the polypropylene have high memory. They coil up like this after we take it out from the packet. So we need to diminish the memory by doing a gentle pull so that we increase the knot security. Biological behavior. Biological or natural sutures such as cadguard are proteolized, which is a process that is not entirely predictable and can cause local irritation. And such materials are therefore seldom used and even banned in some countries. Synthetic polymers are hydrolyzed, and their disappearance in the tissues is more predictable, like the PDS and vikrill. However, the presence of pus, urine, and feces influences the final result and renders the outcome more predictable. So they may enhance the absorption of a suture material and even shorter the support time provided by the sutures. The requisites for suture materials are the following: high uniform tensile strength, permitting use of finer sizes. Like if a suture has high tensile strength, we could use a 3-0 instead of a 0 size. And when we use smaller sutures, it's going to be more aesthetic. It's going to leave less scarring, less trauma to the tissues. So we want sutures with high tensile strength so that we can use finer sizes and decrease the tissue trauma and improve the aesthetics. High tensile strength retention in vivo, holding the wound securely throughout the critical healing period, followed by rapid absorption. So not only do we want a high tensile strength in vitro, but when the suture is in the tissues, the tensile strength should be high. They should hold the wound properly, securely during the critical healing period of the wound. And after its work is done, let's say the critical healing period of wound is 2 to 3 weeks, for example, it should act properly in that 2 to 3 weeks. And after that, when it is not required, it should not unnecessarily stay in the tissue forever or for a long period, causing infection, acting as a nidus for infection or stone formation, and they should be rapidly absorbed. The suture materials must be sterile. All suture materials come in a sterile pack, so no need to worry about this, but don't use unsterile suture materials. They should be pliable for ease of handling and knot security. So if you use sutures like vikrill, they are very nice to handle and have good knot security, and you'll have problems with Prolene and PDS regarding this. Freedom from irritating substances or impurities for optimum tissue acceptance. Okay, that's a good point. They should have a predictable performance. because the results that we see in one patient, it should be replicable in another patient. It should not be like the one suture gave very good results in one patient and it has unpredictable performance, so in another patient it gives a very bad result, like it gets absorbed way too soon or does not provide support. So it should have a predictable performance. Prevent or limit bacterial adhesion and proliferation. For that, we need to use monofilament, and the multifilament or polyfilament should be avoided, where you think that there will be more bacterial adhesion and proliferation like in infected tissue. It should have uniform diameter so that it does not, make big holes in the tissues, and it's easier to handle, and the knot is secure. The sutures must not be carcinogenic, and they should be biologically inactive. This catguard and silk, they cause tissue reactions and all that, so these have been banned completely in some countries. Non-absorbable suture materials. Now, silk is a natural non-absorbable suture material. It's a polyfilament. It comes like this in the blue package with white, and it has a black thread, and this is a silk black thread. Now, it's braided or twisted multifilament. It can come as dyed or undyed. It may be coated or uncoated. If it's coated, it is coated with wax or silicone, and it is a natural protein. It is derived from raw silk from the silkworm. The tensile strength retention in vivo. It loses 20% of its tensile strength if it is wet, and 80 to 100% of its tensile strength is lost by 6 months. Let's take a look at absorption rate. Fibrous encapsulation in the body occurs at 2 to 3 weeks, and it gets absorbed slowly over 1 to 2 years. Now, silk has a moderate to high tissue reaction, so therefore it is not recommended. Repeatedly I have mentioned it's not recommended. It should definitely not be used on the face. You can suture some wounds in the legs or maybe in the abdomen, where it is where osmosis is not important, and if something else is not available, it's used for fixing drains, because you're going to just take one bite in the skin, you want to fix the drain, then silk may be used. Contraindications, and silk is commonly used for tying vessels in surgeries. Contraindications: not for use with vascular prosthesis or in tissues requiring prolonged approximation under stress. Now, it said that it loses 20% strength, 80 to 100% lost by 6 months. So if you need prolonged approximation under stress, silk should not be used, and not to be used at all with vascular prosthesis. It's frequently used in ligation and suturing when long-term tissue support is necessary, because it will stay for at least 6 months, and for securing grains externally. It can come from the size of 10-0 to 2 with needles, and 4-0 to 1 without needles. Then we have linen. Linen is a twisted suture with the raw materials are long staple flax fibers. They are stronger when wet, and they lose 50% of the strength at 6 months, and 30% of the strength remains even at 2 years. Linen is non-absorbable and remains encapsulated in body tissues. They have moderate amount of tissue reaction, and they are not advised for use with vascular prosthesis. They are frequently used for ligation and suturing in gastrointestinal surgery, no longer in common use in most centers, and they are available from 3-0 to size 1 with needles, and 3-0 to size 1 without needles as well. Now, surgical steel. Obviously, it is non-absorbable. They can come as monofilament or multifilament. The raw material used for the production is an alloy of iron, nickel, and chromium, that is steel. It has infinite tensile strength in vivo, that is more than 1 year. And the absorption rate is it is there's no mention about no need to talk about absorption rate because it's non-absorbable and remains encapsulated in body tissues. The tissue reaction is minimal. There's no the contraindication is that it should not be used in conjunction with prosthesis of different metal. It's frequently used in closure of sternotomy wounds and previously found favor for tendon and hernia repairs, but not anymore. They are supplied as monofilament sutures at size 50 to 5 with needles, and as multifilament with needles in the size of 50 to 30. Then we have nylon, which are available as monofilament or braided multifilament. They can be dyed or undyed. The raw material is polyamide polymer, and it loses 15 to 20% of the tensile strength per year, and it degrades at approximately 15 to 20% per year. So it degrades, it loses tensile strength at the same rate that it degrades. The nylon has low tissue reaction. There are no contraindications for nylon as such. They are frequently used for skin closure, abdominal wall mass closure, hernia repair, plastic surgery, neurosurgery, microsurgery, ophthalmic surgery. Nylon is a bit similar to polypropylene, and it's much cheaper. They're supplied in form of monofilament with needles, without needles. It can be available from 11.0 to 2 with needles in monofilament, 4.0 to 2 without needles. It's also available as multifilaments with in the size 6.0 to 2 with needles, 3.0 to 1 without needles. Now polyester. So polyester has green packet, green suture, and it's multi-filament braided. So it can be available as monofilament or braided multifilament, dyed or undyed. It can be coated with polybutylate or silicone, or it may be uncoated. The raw material of polyester is polyethylene terephthalate. The tensile strength retention in vivo is infinite. It is more than 1 year. When we say infinite, it's more than 1 year. It's not 1,000 years. The absorption rate it's non-absorbable, and it remains encapsulated in body tissues. Polyester has a low tissue reaction. There are no contraindications as such, and it's frequently used in cardiovascular, ophthalmic, plastic, and general surgery. They are supplied as monofilament ophthalmic sutures in the size 11.0 or 10.0 with needles, and as multifilament in the size 5.0 to 1 with needles. So monofilament is 11.0 and 10.0, and multifilament is 5.0 to 1. Polybutylene. It's blue in color. I've written here blue. It's a monofilament suture, can be dyed or undyed. The raw material is polybutylene terephthalate and polytetramethylene ether glycol. More than 1 year tensile strength. It's non-absorbable, and it remains encapsulated in body tissues. It has low tissue reaction, no contraindications as such, and exhibits a degree of elasticity, and therefore particularly favored for use in plastic surgery. So polybutylene, interesting point is it exhibits a degree of elasticity, and it's supplied from size 7.0 to 1 with needles. Now polypropylene, see how many varieties are there. It's blue in color, it's a white and blue color. So silk was also white and blue packaging, but it was black in color. And they can be single needle, double needle, round body needle, cutting needle, straight needle, reverse cutting needle, double needle, taper cut. So there are lots of variety. It's a monofilament suture which may be dyed or undyed. The raw material is polymer of polypropylene. It's a polymer of propylene, that's why it's called polypropylene. Infinite tensile strength, that's more than 1 year. It's non-absorbable, it remains encapsulated in body tissues, and it has low tissue reaction, no contraindications as such, and it is frequently used in cardiovascular surgery, plastic surgery, ophthalmic surgery, general surgery, and can be used for subcuticular skin closure, but they have to be removed since they are non-absorbable, and they are supplied from size 10-0 to 1 with needles. Now let's take a look at absorbable suture materials. We have plain cadguard. Look at the color of the cadguard. It's straw colored or yellowish brown. It's plain. I've been using this color of the suture as the background over here. Like this is yellow. You can see it was blue in Proline. The raw material used for cadguard is collagen derived from healthy sheep or cattle. It's from the intestine, submucosa of healthy sheep or cattle. The tensile strength is lost within 7 to 10 days, and there is marked patient variability. Tensile strength may be more or less in different patients, and it is unpredictable and it is not recommended. It gets absorbed by phagocytosis and enzymatic degradation within 7 to 10 days. There is high tissue reaction. It is not recommended, unpredictable. It is not recommended. Remember these points about cadguard. This should be cadguard plain. There's a mistake over here. It is not for use in tissues that heal slowly and require prolonged support because it's unpredictable tensile strength. It's going to lose its strength in 7 to 10 days. Synthetic absorbables are superior, like vikrill, rapide. They were, and in some places are still used to ligate superficial vessels and suture subcutaneous tissues, and for stomas and other tissues that heal rapidly and which do not require prolonged support. They are available as from size 6-0 to 1 with needles and 4-0 to 3 without needles. Now we have chromic cadguard. They have a slightly darker color than the plain cadguard. So they are chromic tanned with chromium salts to improve handling and to resist degradation in tissues. The chromic cadguard is derived from collagen from the submucosa of intestines of healthy sheep or cattle, and they are chromic tanned with chromium salts. They lose their tensile strength within 21 to 28 days. Again, marked patient variability is there. It's unpredictable. It's not recommended. Absorption is by phagocytosis and enzymatic degradation within 90 days. If you want to revise again, that was absorption in 7 to 10 days for plain cadguard. It's 90 days for chromic cadguard. It has moderate tissue reaction. It's not for use in tissues that heal slowly and require prolonged support. Synthetic absorbables are superior. They are frequently used for ligating superficial vessels to suture subcutaneous tissues and for stomas and other tissues that heal rapidly, and they are available from size 6-0 to 3 with needles and 5-0 to 3 without needles. Then we have a very commonly used suture material that's called vikrill. It's the brand name. It's also known as polyglectin 910. It's a braided multifilament suture. It's made from copolymer of lactide and glycolide in a ratio of 90:10. That's why it's called 910. 90 lactide, 10 glycolide. So it has the name polyglectin 910. Approximately 60% of tensile strength remains at 2 weeks and approximately 30% remains at 3 weeks, and its absorption is by hydrolysis, which is minimal until 5 to 6 weeks, and after that hydrolysis increases and there's complete absorption by 60 to 90 days. And there can be a type called vikrill rapide, which gets absorbed very fast. And we have vikrill plus, in which there's antibacterial coating with Ergacare MP, and it can be undyed white in color, it can be violet in color for the dyed. It has mild tissue reaction. It's not advised for use in tissues that require prolonged approximation under stress because it's going to get hydrolyzed and get absorbed very soon in a couple of months. It's a workhorse suture for many applications in general surgical practices, including the undyed vikrill for subcuticular wound closures. And it's also used in ophthalmic surgery. It's available from 8-0 to 2-0 with needles, 5-0 to 2 8022 with needles, 5022 without needles. Then we have Maxon, that's a brand name. Polyglyconate is the suture. It's a monofilament. It may be dyed or undyed. It's made from copolymer of glycolic acid and trimethylene carbonate. Approximately 70% remains at 2 weeks and approximately 55% remains at 3 weeks. 70% of tensile strain remains at 2 weeks, 55% tensile strain remains at 3 weeks. Hydrolysis is minimal until 8 to 9 weeks, after which it increases and complete absorption takes place by 180 days. It has a mild tissue reaction and is not for use with vascular processes or in tissues requiring prolonged approximation under stress. It is popular in some centers as an alternative to vikrill and PDS. You might forget, we are talking of Maxon. I'm again mentioning the brand names, not to promote the brand names or anything, but because a lot of us don't remember these polyglyconate, polyglectin, polyglycaprone. We remember the brand names like vikrill, Maxon, Ethylone. So just to make it easier for some of you to memorize the points, we're talking about Maxon over here. They're supplied in size 7022 with needles. Then we have polyglycolic acid sutures. So they are purple in color. They are braided multifilament sutures. They may be dyed or undyed, coated or uncoated, and they are a polymer of polyglycolic acid. They are available with coating of inert absorbable surfactant Polyoxamer 188 to enhance surface smoothness, and 85% of this coating is excreted in urine within 3 days. If you look at the tensile strength of this suture polyglycolic acid, approximately 40% remains at 1 week and approximately 20% of the tensile strength remains at 3 weeks. It gets absorbed by hydrolysis, which is minimal at 2 weeks and significant at or after 4 weeks, and it gets completely absorbed by 60 to 90 days. The tissue reaction is minimal. Minimal is less than mild. In some of the sutures, I've mentioned high, which is more than moderate. Then after moderate is mild, and then we have minimal. So you can go back and look at which sutures had mild tissue reaction. So this minimal will have less tissue reaction than the mild ones. They are not for use with vascular processes or in tissues requiring prolonged approximation under stress, and they are frequently used similar to the uses for other absorbable sutures, in particular where slightly longer wound support is required, because here we have till about 1 or 2 weeks, like 14 days, 20 days, we still have some strength over here. In other absorbable sutures, they lose strength by 10 days, like for cadguard and vikrill rapide. They are supplied as 90 to size 2 with needles and 90 to size 2 without needles. Then polydioxanone, PDS, commonly known as PDS, they have a slightly dark purple, violet or purple, dark purple color, and it's a late absorbable suture. It's monofilament, dyed or undyed. The raw material used for making polydioxanone is polyester polymer. Approximately 70% of the tensile strength remains at 2 weeks, approximately 50% tensile strength remains at 4 weeks, and approximately 14% tensile strength remains at 8 weeks. It gets absorbed by hydrolysis, which is minimal up to 90 days, and after that this hydrolysis increases and there is complete absorption by 180 to 210 days. It has a mild tissue reaction. Contraindications for use of PDS is in association with heart valves or synthetic grafts in situations in which prolonged tissue approximation under stress is required. There we would prefer to use non-absorbable sutures, of course. Frequent uses are this term, this phrase over here, in situations in which prolonged tissue approximation under stress is required, is a contraindication. This is a very relative thing. Like We use polydioxanone to close laparotomy muscle wounds, and it provides prolonged tissue approximation, right? So in some wounds require closure, very slight support. We don't use PDS over there. Some require very good support, like in big laparotomy wounds, midline laparotomy. There we want to use PDS. But then again, if you want prolonged tissue approximation under stress, then again we are not going to use polydioxanone. That's what we are trying to say over here. It's frequently used as for other absorber sutures, in particular where slightly longer wound support is required. They're supplied as 10-0 to 2 with needles. Polyglectin, most difficult one to memorize for a young student. Polyglectin, it's very difficult to say it. You'll hear this word and after a couple of days you'll forget it. Polyglectin, it is yellowish, or what should I say? It has an orange packet and yellowish suture, yellowish white. Not yellowish white, I should say very pale yellow color. It's monofilament. It's made of copolymer of glycolide and caprolactone. Tensile strength is 21 days maximum, and it gets absorbed by 90 to 120 days. It has a mild tissue reaction. It should not be used for extended support. It's frequently used for subcuticular closure in skin, for ligation, in gastrointestinal and muscle surgery. It's supplied as 8-0 size to 2 with needles. The ideal suture should be, the points about ideal suture are that it can be utilized in any operation, it can be handled easily and comfortably, minimal tissue reaction by the suture. It should have a high breaking strength, high tensile strength. It should have high knot security. It does not cut, tear or shrink the tissues. It must be non-allergenic and non-carcinogenic. The ideal suture is absorbed predictably with no tissue reaction, and it is reasonably priced. Barbed surgical sutures. Now, recently, novel suture materials has helped surgeons to reduce or eradicate the need for knot tying in some situations such as laparoscopic surgery. Like when you're doing laparoscopic surgery, you don't want to, inside, you're using instruments, you have to make knots and all. It's quite difficult, and it's easy only for some surgeons, and you don't want to, keep making knots laparoscopically. So barbed sutures has helped surgeons a lot in these situations. So these sutures have unidirectional or bidirectional barbs that secure the sutures in the tissue. Like you take the bite, you pull it to where you want, till where you want to, and it gets secured. Now let's take a look at needles. Surgical needles are designed to lead the suture material through tissues with minimal injury. In the past, needles had eyes in them and suture materials had to be loaded. It was time consuming, and needle holes in tissues were considerably larger than the suture material. Therefore, it would create a bigger hole in the tissues than was required for the sutures to pass through. Currently, needles are eyeless or atraumatic, with the suture material embedded within the shank of the needle. The needle has three main parts: the shank, the body, and the point. This is the shank, this is the body, and this is the point. Now, the classification of surgical needles can be done according to eyes, eyeless needles, or needle with eyes. These days, we are using eyeless needles. According to shape, a straight needle and curved needles. We'll commonly see curved needles these days. According to the cutting edge, it may be a round body, a cutting, conventional cutting, or reverse cutting. So it can be a round body, conventional cutting or reverse cutting. According to the tip may be triangular tip, round tip, or blunt tip. The surgeon must grasp the needle approximately 1/3 to 1/2 of the way back from the rear of the needle. This is the rear of the needle. This is the 1/3, 1/2 from the rear. If you're coming from the rear, it's 1/3 to 1/2. So grasp the needle in between this area. Avoid the shank and the point. The closer the needle holder is to the tip of the needle, the greater the accuracy of suture placement. So if you hold here, closer to the tip of the needle, accuracy will be more, and less the degree of rotation of the surgeon's hand is required. If you hold it near the swedged end, you have to twist your hand more in order to place the suture. The needle should never be grasped near than 1/3 of the way back from the rear of the needle. Don't grasp it over here. The body of the needle can be round, triangular, or flattened. The round-bodied needles gradually taper to a point, while triangular needles have cutting edges along all three sides. The actual point of the needle can be round with the tapered end, conventional cutting, which has the cutting edge facing the inside of a needle's curvature, or reverse cutting, in which the cutting edge is on the outside. So in the conventional cutting, the inner concave side of the needle is sharp. This side is sharp, so it cuts. So it cuts on the inner side, and in the reverse cutting, the outside, the convex side is cut. So if you use a conventional cutting, when you pass the needle like this and it goes through like this, it cuts on the inner surface. So when you pull the suture, you have cut on this side. So there are more chances of the tissue tearing through because you have cut the inner side toward which you are going to pull the suture. But in case of a reverse cutting, you slice the tissues on the outer side, and you're going to pull the sutures towards each other. So you've cut on the outside, slice on the outside, and you're pulling the tissues together on this side. So the chances of tissue cutting or cutting through is less. Let's take a look at what's written in the theory in the book. The taper point is suited for soft tissues. That's correct. It dilates rather than cuts. The reverse cutting is very sharp. It's ideal for skin and hard tissues like that. It cuts rather than dilates. Correct. Conventional cutting is very sharp, cuts rather than dilates, same as reverse cutting, but it creates weakness, allowing suture tear out. This is the point I was saying. It cuts on the inner side. So when you pull the suture, this suture tear out. Taper cutting is ideal in tough or calcified tissues, mainly used in cardiac and vascular procedures. Round-bodied needles are designed to separate tissue fibers rather than cut through them, and are commonly used in intestine and cardiovascular surgery. Cutting needles are used where tough or dense tissue needs to be sutured, such as skin and fascia. The choice of needle shape is dictated by the accessibility of the tissue to be sutured, and the more confined the operative space, the more curved the needle that we should prefer. Handheld straight needles may be used on skin. Needle holders should be used in all cases to reduce the risk of needle stick injuries. It's just written just like that. No one is using handheld needles anymore. It's just a theoretical point. So they can be half circle needles, 3x8 circle, half circle, 1x2 circle, a quarter circle, 3x8, a half circle, 5x8, a J-shaped needle, compound, curved, or a straight needle. The alternatives to needles are steri-strips and staples. Skin adhesive strips are available, which may be used when there is no tension and not too much moisture, such as after a wide excision of a breast lump. may also be used to minimize spreading of a scar. Other adhesive polyurethane films such as Opside, Tegaderm or Biocclusive may provide a similar benefit, while such transparent dressings also allow wound inspection and may protect against cross-infection. Tissue glue. These are based upon a solution of N-butyl-2-cyanoacrylate monomer. The wound needs to be clean, dry, with near perfect hemostasis and under no tension. When it is applied to a wound, it polymerizes to form a firm adhesive bond. Although it is relatively expensive, it is quick to use, avoids anesthetic and sutures. It does not delay wound healing, and it is associated with an allegedly low infection rate. Other tissue glues involve fibrin and work on the principles of converting fibrinogen to fibrin by thrombin with cross-linking by factor 13. The addition of aproteinin to slow the breaking up of the fibrin network by plasmin is done. This process has good adhesive properties. Fibrin glue uses are hemostasis in the liver and spleen, for dural tears, in ear, nose and throat, and ophthalmic surgeries, to attach skin grafts to prevent hemoserous collections under flaps, and it's also been used to control gastrointestinal hemorrhage endoscopically. Fibrin glue, they do not work when the bleeding is brisk. Skin staplers are a rapid and effective method for closing long skin incisions. There is a 3 to 4-fold reduction in time for skin closure. It therefore requires less anesthesia and operative time because we are making the process faster. There's less tissue reaction by these staples than using some of the sutures. The staples are less likely to carry an organism into the wound compared to sutures, but they require painful removal and are not as comfortable as sutures for the patient. The mechanical stapling devices were first used successfully by Hummer Huttel in Hungary in 1908 to close the stomach after resection. These are surgical staples, not the skin staples that I just talked about in the previous slide. Today, a wide range of mechanical devices that can be used both in the open surgery setting and laparoscopically are available. Most of these devices are disposable and relatively expensive. Their cost is offset by the saving of operative time and the potential increase in the range of surgery possible with them. In the gastrointestinal tract, stapling devices tend to apply 2 rows of staples offset in relation to each other to produce a sound anastomosis. Many of them also simultaneously divide the bowel or tissue that have been stapled, while other devices merely insert the staples and the bowel has to be divided separately. For all stapling devices, it is crucial for the surgeon to understand the principles behind the device and to know intimately the mechanism and function of the instrument. Then there is something known as end-to-end anastomosis staplers. Circular stapling devices allow tubes to be joined together such as instruments, and such instruments are in common use in the esophagus and lower rectum. The detached stapling head or the anvil is introduced into one end of the bowel. The bowel of the device is then inserted into the other end of the bowel. The shaft is either extended through a small opening in the bowel wall or secured by a further purse string suture. So this device has been put in one end, this has been put in the other end. They come in contact and this creates this suture, and this line is sutured, so it saves time. Then there are staplers for transverse anastomosis. They provide 2 rows of staples for single transverse anastomosis. They are useful for closing bowel ends, and the larger sizes have been used to create gastric tubes and gastric partitioning. One technical point of importance is that the bowel should be divided before the instrument is reopened after firing. The instrument is designed with a ridge along which to pass a scalpel to ensure that the cuff of bowel that remains adjacent to the staple line is of the correct length. Then there are devices for intraluminal anastomosis. These instruments have 2 limbs which can be detached. Each limb is introduced into a loop of bowel, the limbs reassembled and the device closed. On firing, 2 rows of staples are inserted either side of the divided bowel. the division occurring by means of a built-in blade that is activated at the same time as the insertion of staples. Such an instrument may be used in fashioning a gastrojejunostomy or jejunojejunectomy and is used in ileal pouch formation. Similarly, laparoscopic stapling devices are there. Many of the intestinal stapling devices are now adapted to be inserted down trocars during laparoscopic surgery. And although they look very different, the principles of function are identical to their open surgical equivalent. The linear cutting staplers allow bowel and blood vessels to be sealed and divided. Linear and circular staplers also allow intracorporeal anastomosis to be performed. As with open staplers, the surgeon must be trained in their safe use and be aware of the principles, including the different staple sizes. Thanks a lot for watching this video. I hope you enjoyed it.